North Georgia is a region stitched together by winding roads, old mills, and family ties that run as deep as the rivers cutting through its hills. It's a place where people know their neighbors, where the morning fog rolls off the Blue Ridge like clockwork, and where tradition often takes the front seat over change. But behind the beauty and stillness, there's a shadow. Over the past few years, I've watched our region wrestle with something quieter than a storm but far more devastating: the opioid crisis. It shows up in empty seats at church, in the quiet grief of a mother who stopped asking, "Where is he?" and started asking, "Was it fentanyl?" It shows up in the headlines, yes, but more often it shows up in silence. I didn't come into this project with all the answers. I came in with questions and a growing realization that the most dangerous part of this crisis isn't just the drug, it's the distance. Distance between users and care, between rural roads and first responders, between stigma and support, and most tragically, the distance between someone overdosing and someone noticing in time. My name is Chase Driver. This is my journey to create a solution built not just with technology, but with urgency, empathy, and homegrown resolutions. Between 2019 and 2021, opioid-related deaths in Georgia increased by more than 200%. In North Georgia specifically, counties like Lumpkin and Fannin now have overdose fatality rates above 35 per 100,000 residents. That's more than triple what's considered a high-risk threshold. Fentanyl, a synthetic opioid up to 100 times more potent than morphine, is now involved in 3 out of 4 overdose deaths. These are not isolated incidents. They are part of a growing systemic failure. This month, the DEA seized over 214 pounds of fentanyl from a massive pill pressing lab in suburban Atlanta. That's enough to kill 48 million people. The bust occurred just 2 miles from an elementary school. These headlines aren't just shocking, they're deeply personal to the region I'm studying. And for rural communities like those in North Georgia, the problem is magnified by isolation. Most overdose victims die alone, without anyone nearby to call for help or administer naloxone. My environmental scan, guided by a pestle analysis, helped me understand external forces shaping this issue. Political. While state-level support for harm reduction exists, rural counties lack the infrastructure to implement it. Economic. 1 in 5 households in Appalachian Georgia lives below the poverty line. Many residents have lost employer-based insurance and access to care. Social. Stigma remains a powerful deterrent. Many users avoid treatment out of shame or fear of judgment. Technological. Over 30% of households lack broadband access, limiting the effectiveness of telehealth and smart interventions. Environmental. Rugged terrain slows EMS response. Legal. Naloxone is legal, but access is uneven, especially in EMS fleets with tight budgets. These systemic barriers make intervention harder, treatment slower, and overdose more deadly, especially in rural communities. But numbers and frameworks can only tell part of the story. To truly understand the problem, I had to talk to the people living it. I conducted over 75 interviews and surveys with EMS responders, people in recovery, and grieving family members. Their stories shaped everything that came next. One paramedic told me, "The problem isn't just overdose. It's that by the time we get there, it's already too late." That insight reframed everything. If the problem is that help arrives too late, then maybe the solution isn't just more treatment centers or awareness campaigns. Maybe it's a way to trigger help automatically the moment it's needed most. That's what led me to create PulsePoint. Welcome to PulsePoint, a lifeline when you're alone. PulsePoint is a smart wearable device for overdose intervention. PulsePoint's mission is to save lives by closing the fatal gap between opioid overdose and emergency response. Through real-time biometric monitoring and automatic alert technology, we empower individuals, caregivers, and rural communities with tools that act when every second counts. even when no one else is there. PulsePoint is an IoT-enabled wearable intervention system designed to detect early signs of overdose and immediately alert emergency services, caregivers, or designated community responders. This isn't a fitness tracker. It's not a consumer gadget. PulsePoint is purpose-built for people at risk of overdose, especially those who use alone. The system includes two form factors to match different user needs, comfort levels, and stigma sensitivities. Both use a waterproof silicone build and carry an IP67 rating for daily use. The first version is PulsePoint Watch with Display. This model features a digital screen for real-time biometrics. It is ideal for users who want feedback or are engaged in recovery. It has a touchscreen interface for device settings and quick checks. The second version is PulsePoint Band with no display. This model is thinner and more discreet with no screen. It is small with external status light to verify it's on and working. This model is designed for people who want maximum privacy in sensitive environments. PulsePoint adapts to the user, not the other way around. PulsePoint uses real-time biometric monitoring to track blood oxygen saturation, heart rate variability, and motion and immobility. If the system detects a dangerous pattern, like falling oxygen and no movement, it triggers an automatic alert to a caregiver or emergency response. Key features in both devices include emergency alerts with custom messages, health history log, SpO2 and heart rate sensors, accelerometer for motion/immobility, Bluetooth or eSIM fallback for connectivity, real-time GPS location tracking, secure cloud access for caregivers/EMTs, and USB-C magnetic charging. The user doesn't have to press a button. They don't even need to be conscious. That's the whole point. PulsePoint is a lifeline when you're alone. Every wearable connects to a secure web-based dashboard. It allows family responders or healthcare providers to monitor vitals in real time, access alert history, and glue last known location. It's mobile accessible, HIPAA compliant, and password protected, enabling fast response from anywhere. Anyone can be granted access with certain permissions. You can also monitor multiple devices. I've developed a 6-week pilot in Lumpkin and Fannin counties. Weeks 1 through 2, onboard partners and train responders. Weeks 3 through 4, deploy 50 PulsePoint devices to at-risk users. Weeks 5 through 6, collect user data, refine product, and evaluate alert success. This pilot will help test alert logic, user adoption, and operational readiness in real communities. PulsePoint costs about $150 per user annually, including monitoring and support. That's less than 50 cents per day. Our funding strategy currently includes a public health model, funded by SAMHSA or opioid response grants and distributed via county health departments. A social enterprise model, rehab centers or hospitals included in discharge plans with costs reimbursed via Medicaid. According to the CDC, each overdose death costs over $1 million. Preventing just a few deaths per county delivers a significant return, not just financially, but in lives saved and families kept whole. And the reason PulsePoint is ready to do that isn't luck. It's the result of a structured innovation process and driven by data. Throughout this project, I've used a range of innovation strategies, not just as theory, but as tools to guide real decisions, clarify direction, and make sense of a deeply complex crisis. Let me briefly walk you through each method and why it mattered. Think Bigger framework. Sheena Iyengar. This framework helped me avoid getting overwhelmed by the scale of drug-related deaths in North Georgia. Instead of trying to solve every part of the problem at once, opioid crisis, unemployment, rural infrastructure, I used Think Bigger to identify the specific moment where the risk was greatest and innovation was possible, the moment of overdose, particularly when the person is alone. That focus allowed me to define a solvable opportunity inside a seemingly unsolvable problem. Open innovation, Henry Chesbrough. Open innovation helped me step outside traditional silos. Rather than relying solely on academic sources or government data, I looked at case studies from Canada, the Netherlands, Baltimore, and Columbus. Places using wearables, kiosks, or data dashboards to reduce overdoses. This comparative lens opened new possibilities and allowed me to pull in ideas from systems that have already been tested, saving time, resources, and helping avoid past mistakes. It also encouraged me to seek collaborators outside my discipline, like public health officials and technologists, who are already working on similar problems. Democratizing innovation. Eric von Hippel. This approach reminded me that the best insights often come from the people closest to the problem. For me, that meant centering individuals in recovery, EMS workers, and families affected by overdose. I designed my surveys and interviews with one goal: to let the community help shape the project. Instead of imposing a solution, I listened. What emerged were key design principles. The solution must be discreet, must not require user interaction during an overdose, and must be trusted. These insights will directly guide any prototype I pursue. Wisdom of the crowds. James Surowiecki. This model emphasizes that large groups of informed people, especially diverse ones, can often predict outcomes better than experts. This directly informed my plan to collect 75 plus community survey responses and 10 plus stakeholder interviews. The goal wasn't just validation, it was collective sense making. Through this crowdsourced feedback, I was able to identify consistent pain points, prioritize user needs, and refine my how might we questions to reflect the lived experience of real people in rural North Georgia. Together, these models form the foundation for every strategic decision I've made so far. They help me frame the right problem, engage the right people, gather the right insights, and begin imagining the right kind of solution, not just one that's technically feasible, but one that's meaningful, equitable, and scalable. Most people who die from an overdose don't intend to. They don't make a call, they don't reach the hospital. In rural places like North Georgia, they're often found too late. PulsePoint is more than a product. It's a lifeline for those moments when no one else is there. It buys time, it alerts help, and sometimes it changes everything. This course challenged me to build something real, not just an idea, but a system that could save lives. I learned that true innovation doesn't start with an app. It starts with empathy, with people, with deep listening. One mother told me, "I used to think tech couldn't help someone like my son, but now I just wish we'd had something like this last year." That grounded me. That's why I kept going. To future students, use your frameworks early. They're your GPS. Fall in love with the problem, not your first idea. Stay close to the community. That's where the answers are. I'm proud of PulsePoint, but I'm even more proud of the process. My name is Chase Driver, and this was my innovation journey. Thank you.